Okay, our next speaker is Dr. Tomas Aleman, the other half of leadership of the Center for Hereditary Retinal Degenerations, and also the PI of many ongoing clinical trials here at Penn. And he'll be talking today about improving vision by gene therapy in really some of the most severe inherited retinal diseases.
Good morning, everyone, and thank you for the invitation to present here. I'm hoping I'm not messing up the audio because I'm shorter than Art and I'm closer to the microphone, but I'm going the old-fashioned way too. So I'm going to present to you basically something a little bit different from, it's the same disease, but a different kind of problem, and that is a severe retinal degeneration, also within the group of degenerations that you call LCA, but that typically can cause more problems in the retina early on, structural problems. Just as disclosures, I hold intellectual property on the development of a visual reality mobility and orientation test. And this study was funded initially by Opus Genetics and the Foundation Finding Blindness through them. So we're going to be discussing basically the safety and efficacy of a gene-based treatment in a different area, as I just mentioned, LCA, and I will go over that in a minute. And I hope that during the presentation, you're going to see the path that we walked through, which led to a clinical trial in a relatively short period of time. And of course, to do anything like this requires lots of people, and these are the list of our collaborators over the years from gene identification in late 1990s to the clinical trial stage. And my closest family, that includes, they are not pictured there, but Drew Scholes, Catherine Uhasey, and Erin O'Neill, which were actually medical directors at the beginning of the trial. They exchanged positions on the way. And our mentor, Sam Jacobson, which guided us into basically everything that we do for LCA. So Arthur and Eric before me have presented some of the images of patients with LCA caused by Gaucher 2D, RP65, and CEP290. And in all three examples, the typical theme is that you have retinas that are relatively spare, and that's good and nice. And years ago, again, guided by Sam Jacobson, we had described and presented this as an ideal scenarios for gene therapy. And the reason for that is that you have this kind of relationship in a situation like this where you have preserved retina, but very bad vision. Let me see if I can do that. So you have basically patients that are with various degrees of preservation of the ONL thickness or photoreceptor preservation, but very bad vision, basically undetectable along the horizontal axis. And the idea is that you can treat and move the relationship to the left when you do gene therapy. In LCA5, which is a form of LCA, that happens very early in the disease, but often by the time patients get to their adolescence, and unlike CEP290, for example, that Arthur presented to you, there is actually severe vision loss, and you don't have to know too much about the retina to know that P3 is really a nasty-looking retinal structure. So can you treat in that situation? So LCA5 presented the opportunity to do that, not only because of the fact that it has a well-identified gene, but it's a gene that encodes a protein of the outer segment, or the base of the outer segment, that is involved in the morphogenesis and perhaps transport of molecules. And the idea was that even if you had loss of photoreceptors, whatever was left there could basically regenerate the photoreceptor outer segment, and with that vision. So why not try it on LCA5, despite the fact that we knew it was going to be a challenge. In the work done at the Kirby Center, a vector, an A vector was devised at the Jim Bennett's group that carried the LCA5 gene, and we confirmed that there was very strong expression of the protein in the mouse model of this disease, which, by the way, is a exceptionally good model of the disease. It shows very, very early and rapid degeneration. And soon after, of course, we did the study in the same mouse where we transfected the retina and proved both histological rescue, both by SST, by OCT, by histology, as well as by ERG. So there was rescue of the phenotype, especially when you treat it earlier in the disease, and Catherine Uhesi led that effort. So that basically provided the proof of concept that we could do the same in patients. But we were still worried about it because of the severity of the disease. But nevertheless, basically 5 years after the initial experiments, we had submitted the IND and were ready to start a clinical trial, which was done through, again, the sponsorship of Opus Genetic, which is a company that is initially funded by patients, basically by the FFB. It's a phase 1/2 open label gene augmentation uniocular subretinal delivery of OPX LCA5. It's not non-randomized like most gene therapy are, and originally was thought to be, or was planned to be, we're changing our minds because of the results, that it could be a gene augmentation trial, like model after the trials that we had done before, and that initially 3 patients would integrate, would basically participate in each one of the 3 planned doses. I'm going to present to you the results for only one dose, the lowest dose, in 3 patients at 1 year. So there were many readouts included in the planning of the trial, but for brevity, we are going to talk mainly about the safety, which was mainly assessed with basically dose toxicity limiting changes and changes in retinal structure, as well as some functional measures, mainly FST, pupillometry, acuity, microperimetry, and mobility. The patients that you select in such a study, you have to actually bias the selection to patients who are severely affected, even within severe diseases. And because of that, you can see here in this table, the best acuity that we had for the 3 patients that were included was 200. The first patient acuity was actually unmeasurable. He was a hand motion braille patient that we have known since 1998, as he was a 1-year-old child. He only had hand motions his entire life, was braille dependent patient, so very severe amount of severe disease. The phenotype is kind of the same depending on where in the disease process you look at these patients. All 3 patients are very severe. These are pictures of their fundus autofluorescence using blue light or short wavelength autofluorescence. In the case on the left, is very little autofluorescence left. The middle patient has some of autofluorescence both in the center and the mid-periphery, and the last patient only autofluorescence in the center, which, by the way, doesn't go necessarily with acuity. We will go over that in a second. The injections went very well. For years now, we favor doing more than 1 injection so that we can produce relatively flat elevations of the retina. And those kind of initial blebs tend to coalesce. So the plan is to, during the so-called fluid-air exchange, to force the bleb to coalesce near the foveal center. So all 3 cases had more than 1 injection, all of them involving the fovea and involving the areas where there was preservation, relative preservation of photoreceptors. In terms of safety, there were only minor side effects, usually associated with the use of steroids. We have adopted the use of PO steroids for about 4 to 6 weeks in most trials, and very high doses initially, and that almost always leads to some side effects, but they are transient. The surgeries were very well tolerated, nothing major to report. These are the OCTs at baseline compared to a year post-treatment, and as you can see, all retinas are reattached. I apologize for the imaging fans. The so that you know the images on the left are taken from a patient with nystagmus, cataracts, and keratoconus, and loss of vision. So not easy to do, but nevertheless, in all three cases, the retinas before and a year later are very similar, thus supporting safety. Arthur has talked to you about FST in more detail, and before Eric also alluded to this. This is a test where we measure the sensitivity of the across the entire retina of the area that has the maximal sensitivity, and we do that by using usually the common application is using two colors to try to figure out basically who is participating in the response, rods or cones. In this case, red bars are it represents the stimulus used in the study. The red stimulus, blue bars with the blue stimulus, and this is a comparison from baseline to month 6, comparing the control eye to the left to the study eye. As you can see on the left, which is the first patient, that black arrow indicates the change of sensitivity, which is in over 1.5 log units, so near 100-fold changes in sensitivity. The vertical arrow is almost not diagonal, but vertical, and that was maintained over the observation interval. Notice that both bars, blue and red bar, are changing in the same proportion, which implies that the photoreceptor mechanism, in this case cones, did not change after treatment. And the same is true for the last patient on the right. The middle patient doesn't have a very pronounced effect, and there is a reason for that. So we know very well that patient 3 and 4 are patients who are cone-mediated. The patient in the middle is actually a patient that has surprisingly some rod function left. So to kind of ask the question, are the cones in that patient, especially to ask that question in that patient, are the cones then changing and we're not perceiving the change because the cone function is buried underneath the rod function? We did in that patient 0101 light adapted FSTs, and the other 2 patients we could basically use the same dark adapter or light adapter. It didn't matter because they are cone mediated patients, and in all 3 patients there was an increase in sensitivity anywhere from 0.6 to again 1.5 log unit. To the right are plots that are summarizing the results as a change from baseline. The important here to note is that by 1 month after the treatment, there is an average change of about 1 log unit, so 10-fold increases in cone sensitivity that basically persisted over time. And it's a big deal. So the scale for cones is much compressed compared to the scale for rods. So it's basically a massive change in sensitivity in some of these patients approaching the normal limit of cone function. In situations like this, you always want to have something objective to confirm your results, and we have used pupillometry for a long time. These are pupillometry measures in the 3 patients. At baseline are the gray traces post-treatment, the green traces control to the left and the study to the right. And in the 2 patients that had the most changes in dark adapted sensitivity are the patients that you can see that they are faster and bigger responses. So the pupil does confirming objectively the change in sensitivity measured psychophysically. And you can do that across a range of intensities, and we do that all the time. You can use over 4 log units of intensity range and use also chromatic stimulus to know which photoreceptor is participating in the pupil responses. On the left is the raw data. The symbols in green, again, is the post-treatment data 1 year. And as you can see on the study eye, there is a shift of the functions that describe the intensity versus response function, a shift to the left of those curves. On the right plots, we are summarizing the change from baseline. Again, very fast increases in pupil response 1 month post-treatment and staying up for the entire duration of the observation. Visual acuity is what everybody wants to hear. It's very important for patients. It doesn't relate very well to the health of the retina, but we, of course, measured visual acuity using conventional ETRS, and when the patients could not do it, we would use a low vision way of delivering these tests. And the change from baseline average in all of the patients about, again, 0.3 log units or log MART units or 3 lines of acuity change. So there was a change in acuity compared to baseline as well as compared to the contralateral eye of the same magnitude. In one of the patients, this is not always possible, but in one of the patients, it was possible to deliver macroperimetry. On the study eye of 04, you can see that there is a increase in the sensitivity of the retina in the treated eye compared to baseline, which also lasted for at least 12 months. And more importantly, the fixation, which is this cloud of green points, moved to a tight cloud near the foveal center, supporting the notion that the patient increased basically the function of the fovea. And lastly, I'm going to skip the last slide. I'm getting late. We did chromatic gradings, which is basically we present the patient with bars, space, different distances on a chromatic background, red bars on a blue background, blue on a yellow background. And we ask basically, we are asking what is the resolution of the patient in each of these situations. And you can see the acuity, grading acuity on the left and the red to blue condition. There is a 0.3 log unit change in the blue to yellow near a log unit, which is equivalent to 10 lines of acuity gain. In conclusion, gene augmentation demonstrated robust biological efficacy, which we demonstrated through different readouts, and demonstrates that in this case, where there is a severe ongoing neurodegeneration, it's possible to increase vision. We had dosed since then 2 additional patients, which are children now. Dr. Skoll is going to be involved in doing more of that with almost identical results. Thank you.
I think we have time for one question for Tomas.
Tomas, how old do you think would be the optimal patient undergoing therapy here?
We don't know, so that's a quick answer, but probably I would say below age 8. So the younger the better, but we don't know. In most of these experiments, unfortunately, we haven't gone that early. LCA 5 perhaps will be the time to go really early.
Thanks so much.